Good evening, Dr. Sivaji and Dr. Latha. Do you hear my voice clear?
Good evening. Yes, your voice can be heard.
Okay, so we'll just start in a minute till others join us. Hope that they will join us soon because today's lecture will be dense and condensed. So I hope that it will be easily understandable for you. Okay, so let me share you my screen. I'm just waiting for Dr. Eurus for the explanation of the question that he or she asked for, because this will be the first thing that we will start with. Okay, so we are going to start now. So welcome to this new session of our course. Today's session will be about the optics, the human optics and refraction. It will be one of the most condensed lectures, as I told you earlier, and I hope that you will be able to understand it, to grasp all the information that we, and all questions, ideas that we will cover today. So I will start first with the question that Dr. Eurus asked about, which is the question that appeared in the previous years regarding the sixth nerve palsy. So the question is saying that a patient with sixth nerve palsy and he has a sixth nerve related esotropia, and he now sees two images 24 centimeters apart. And this diplopia is present at 6 meters. So the question is asking about what is the angle of squint. So Dr. Eurus, I was waiting for you to explain this question. And then the answers are just, it is 1 or 2 or 4 or 8. So I just made an animation, and unfortunately all was done yesterday. So I tried to start all over again. So here we are. So if we have this image that those eyes are looking at you, and they should be seen single since the eyes are well aligned. However, what happens if one eye is not well aligned? If one eye has esotropia or is turned inward, so then this inward deviation, it is measured in prism diopters. And as we said in the prism lecture, each one prism diopter misalignment will cause at 1 meter will cause deviation of the image at 1 centimeter, meaning that if we have one prism diopter of misalignment of esotropia of this eye, at 1 meter it will cause displacement of the image at 1 meter. So since this eye see normal image, this eye will go with this eye will show or will see the displaced image. So this what will cause what's called uncrossed diplopia. We will get to that in a while at the end of the lecture, meaning that this right eye will see the right image and the left eye will see the left image. So we have two images separated from each other by 1 centimeter apart if they are viewed at 1 meter. This is if the eye has esotropia of 1 prism diopter, according to this rule. So what happens if we just increase the distance instead of 1 meter to be 6 meters? So the angle will increase. So instead of being separated by only 1 centimeter, they will be separated by 6 centimeters. This is if the eye has esotropia of 1 prism diopter. But what happens if the eye has more deviation, more esotropia, like if they have 4 prism diopters, then we will how much or what is the distance between the two images? It will be 6 multiplied by 4 diopters, which will be 24 centimeters. So if we get back to the question again, if they have two images separated 24 centimeters apart at 6 meters, then the prism deviation or the angle of the prism, the angle of deviation will be about or it will be like, what is the deviation? It will be 4 prism diopters. Okay, so is it clear now? Is this question clear?
Yes.
Dr. Yours, it's okay.
Yeah.
Okay, so let's start with our questions today, our lecture or the questions of human optics and refraction. So we'll start with the first question. The lenses have to be of the same effectivity. The concept of lens effectivity. If they form real image or virtual image, this doesn't matter. But what matters is that this image is present at the same point. So if we are placing single lens or multiple lenses, if you are placing single lens or multiple lenses in front of each other and they will form a real or virtual image at the same place, at the same point, then they are called to be of the same effectivity. So in ophthalmic optics, that point is usually the point of the eye. So which one of the following lenses will have equal effectivity are true and false? So if we are saying that lens A and lens B are equally effective, then they must be of the same power. Do you think this is true or wrong? So you can participate.
True.
True?
Yes.
So they have to be of the same power?
Yes.
So let me give you an example. If we have a patient with aphakia, and this patient we have put in lens or glasses in front of his eyes, or we placed a contact lens in front of his eyes, or an intraocular lens within his eyes, all these 3 lenses will be of the same power or not?
No.
No, but will they produce the same image at the same retina of the patient's eye or not?
Yes.
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 So does this mean that they have to be of the same power?
No.
No.
Yes, no, it is not the same power. They don't have to be of the same power to be equally effective. Why is that? Because there is another important factor that we need to take into consideration. And what is that? It is the distance. or the back vertex distance. These back vertex distance are
Yes.
crucial for the effectivity. And we mentioned before that the effectivity is related to the distance from the eye, whether they are moving forward or moving backward. This will affect the retinal image size and hence affect the effectivity. Okay, so I think that the
Yes.
all other options will be easy now. Do they must have the same curvature?
Yes.
No.
No.
No,
Not the same curvature, as
No.
these lenses that don't have the same curvature.
it's a different back vertex distance.
They must have different back vertex distance. So concentrate well. So the question is saying that in order to be equally effective, they must have a different back vertex distance. Is it correct or not?
Yes.
No. No. No.
So
No.
we cannot have lenses with the same power, same refractive index, and same back vertex distance. Will be they of the same effectivity? So that it is related to back vertex distance, but it is not a must to be for equal effectivity to have different back vertex distance. They could have the same back vertex distance and other related factors like the thickness, like the power, like the refractive index, like the lens design, and they could still have the same effectivity. So the question is not true. It is wrong. They don't have to be different back vertex distance, but they could have different back vertex distance. So this is not a must, but they could have different back vertex distances, as we mentioned in the example of aphakia, and they could still have the same effectivity. Okay, so watch out that choice of language. They must have the same refractive index. I think that we all agree that it is no.
Yes.
Has the so
No,
you
wrong.
think that the intraocular lens have the same refractive index of the glasses, like the same of the contact lens? No, this doesn't have to have the same refractive index. So just to summarize the effectivity, the lens effectivity, it is just the change of the vergence of light. Is it the change in the pathway of the light till they reach a certain point? And if different lenses will cause the pathway of the light to reach the same point, then they are said to have equal effectivity. And this is usually related to the vertex distance. Like if we are talking about the eye, if we are moving the lens away from the eye, toward the eye, or away from the eye, then the vergence power at the principal plane of the eye will change. And the focus of the lens and the far point of the eye will no longer coincide.
Sir, excuse me.
Yes, sure. Go on.
In case the question always is written that which is the mostly likely to be true question answer.
The question
always is given that which is the likely possibility.
Yeah, I understand that these questions are from older ICO exams, which were asked specifically about each sentence, whether it is true or wrong. But nowadays, the questions are asking which is the most likely to be true. So if you know which sentence is true or which sentence is wrong, you will be easily able to answer which is the most likely to be true, because you simply exclude all other options. So as I told, I don't know if you attended with us from the start or not, but we are saying that we almost covered all the questions that appeared in the optics exams, which ask about the most correct answer, which is the new system. But we are now covering the old exams, which were asking about whether each statement is true or false. Okay, so this question is asked which statement is true and which is false. So we need to answer each statement separately. This is not the same like what your exam will be look like, because as I told you, these questions are already covered in the comprehensive course, and we don't have extra questions of the most likely to be true type of questions. So we are covering the past older questions, and they have really very good ideas, very good and slightly more tough questions, ideas that I believe that they will be very useful for your understanding of different topics. Does this answer your question?
Yes, yes.
Okay. So back to the lens effectivity. So we mentioned before, if we are just the retinal image size and the magnification will depend whether the lens are plus or minus, and whether they are placed at the f1 or outside f1 or inside f1. So this will result on either in the back vertex distance will increase or decrease, decrease or increase. This will result in the difference in the image size and consequently difference in the lens effectivity. So don't forget that the lens effectivity will depend on the back vertex distance. Okay. Okay, so here is the example that if we are just using the, when I try to think of what is the best example to demonstrate this question, it will be the aphakia. So those who are aphakic have the, if we are just placing a lens at the f1, the f1 is just moving more forward because their f1 is like around 24 millimeters instead of being the standard for 15.6 millimeter of the normal eye. So if we are placing a lens at 24 millimeter, then the power will be 10.4 diopters, and they will still show the same versions. You see the pathway of rays, it will be the same. But what happens if we are just moving forward in the spectacle plane around 13 millimeters from the eye? Then the power of the lens should increase, and it will show the same versions, the same pathway of light rays. And what happens if we move the lens into as a contact lens? So if we are just just hold on. I hope that doesn't do like yesterday. Okay, so it will do like the same error like yesterday. So I learned the lesson and I will not close the presentation. Okay, so if we are just placing the contact lens in front of the eye, or if we place an intraocular lens inside the eye, it will be different lens designs and different back vertex distance, but it will show the same pathway. So it will be different powers, different designs, different refractive indices, but it will show the same everything, the same pathway of light rays. Okay. Okay, so let's now move to the next question. So which one of these substances you think, or the refractive index of the cornea is greater than which one of these substances? Can you tell me? This doesn't need for you to memorize, just by logical thinking.
Sí, aqueous.
Aqueous and what
AC.
else? AC, yes, exactly. Because
Yes, A also, yes.
Because the cornea is like a dense structure, and we have two fluid structures like the vitreous and the aqueous. So it is known by common sense that the cornea will be more than the vitreous and aqueous. And for other substance, no, it will not be true. Is the crystalline lens nucleus specifically, not the cortex, and the polymethyl acrylate, which is the substance that we manufacture the intraocular lens, hard IOL. So it is a hard IOL, it is more dense than the cornea, and the precision optic glass will also be the correct answer. It will have more refractive index than the cornea. So just let me clear this. So these are the refractive indices of the most important substance that you need to know. The air is one, the cornea is 1.376. This figure is important. The aqueous and the vitreous are fluids, and they are about 1.336. And since the aqueous and the vitreous are making the most components of the eye, so the refractive index of the eye as a whole will be also the same, 1.336. The all kinds of glasses will be more than 1.5. So the crown glass or precision glass will be 1.5, and flint glass will be more dense. It will be 1.6. It's compressed glass. The diamond of 2.5. So, and the lens has also different refractive indices, whether they are depending on if they are cortex or if they are nucleus. So if they are cortex, it will be 1.386. If they are nucleus, it will be has more refractive power. It will be about 1.4. So the nucleus or the core of the lens has more refractive index than the cortex. Okay. Okay, let's check the next question. Okay, so try to read these questions carefully. An ametropic patient, so he has some errors of refraction, and with macular degeneration. And what is the importance of saying macular degeneration here? Because this means that the patient has low vision. So he has visual acuity of 660, 20 to 100 in both eyes, and he is using magnifying spectacles of plus 12 diopter. So he used this like a low vision aid, like a magnifying lens, in order to magnify the image and to see clearly. However, he has asthenia and tired eyes when reading and the headache. Which one of the following will cause improvement of his symptoms? So can you tell me why this patient has asthenia and tired eyes when reading and headache?
Stronger than his name.
So do you think that this patient who is ametropic, who is originally ametropic, so he could also have an error of refraction, this 2 diopters, so how many, let's say, how many diopters of magnification does this patient have? Does this patient need? We said in one of the lectures, I don't know if you watched it or not, what's called the custom boom.
Need 10 diopters.
Rule. What is the custom boom rule? Meaning that those patients with low vision aid, yes, exactly, he will need specifically 10 diopters. He will need like 60. He will need the reverse of his Snellen notation. So if his visual acuity is 660, then how can we calculate what is the amount of magnification that he needs? It should be 60 over 6, which will be around 10 diopters. So he will need 10 diopters. Okay, we agree. So first of all, is this very, very accurate ratio for all patients? Answer is no. This is just an estimate. So it could increase or a little bit, decrease a little bit. So depending on the patient's ability to see. So does this patient has a problem in seeing or in magnification? Like, does he report that he cannot see? He is the letters are still small. Actually, no. He is saying that he has asthenia and tired eyes when reading and headache. So it is unlikely that if you are just giving him a 10 diopter instead of 12 diopter, that it will improve his headaches and reading. It will, these 2 diopters are not the key factor of affection or to affect the patient's symptoms in this scenario. Because you don't know if the patient is ametropic or not, and it is that if the patient is ametropic, you could have a +2 before you are giving him the prescription. And again, the problem is not related to magnification. The problem is related to other
Base out
complaints.
prism.
Can you tell me what is the complaint that this patient could have, or what is the underlying problem that this patient could have?
So base out prism required to increase convergence.
Yes, exactly, the convergence. So actually the patient doesn't need 10 diopter or 15 diopter or 5 diopter. Those still, if you could give the patient, it will be, the question is which would be the most likely to improve his symptoms. So which one of those will most likely will improve these symptoms? If you are just giving the 10 diopters, the patient will still have the same problems of headache and the tired eyes and athenia. This is simply because those patients with age-related macular degenerations or elder populations in general, not only they have weak accommodation, but also they have weak convergence. So they need something to help them overcome this weak convergence. And what will be the correct answer? Is it a base out prism or base in prism?
Base out prism.
Base in prism.
Yes, it is the base in prism. That's correct. So this is what we mentioned before about when in the spherical lens lecture, you will find at the end of the lectures, we mentioned something called the prismospheres, which are some kinds of lenses that will not only relieve accommodation, but also they will relieve convergence. So they have magnifying sphere that will relieve accommodation, and also they have prism base in that will relieve convergence. So let's say that if you are just looking at, both eyes are looking to this tree, then we don't have a problem. They are away from the eye, so they don't exert any kind of accommodation or any kind of convergence. But what happens if we are looking at this book? So this book will stimulate the near reflex. And near reflex consists of 3 items. It will cause meiosis, it will cause accommodations, and it will cause convergence. So the eye will how can we help for the accommodation and the convergence? These tasks are required from the eye. We can help for the accommodation by placing plus lenses in front of the eyes. And if the patient has low vision, like age-related macular degeneration, we need to increase the plus lenses. However, we are just improving one component because this eye is in close distance to the eye, so the eyes should look inward, like do convergence. And the fact is that the convergence is stimulated actually by accommodation, like a proximity of the object will stimulate the near reflex triad, and it will stimulate the meiosis, accommodation, and the convergence. And since the patient has no accommodation, or if the patient, we are just relieving the all accommodation with the high plus lenses, so there will be no trigger for convergence for this patient. So the patient will complain of tired eye and the athenia and the headache because he is trying to converge but unable. Either he is unable to converge because of weak convergence, intrinsic weakness of convergence that he suffers from, or because we are already relieving the accommodation, so we are relieving the stimulus for convergence, but still the patient need to move his eyes inward because the book is near to his eyes. So we have 2 solutions. Either that we are bringing the image to the eye or bring the eye to the image. How can we bring the eye to the image? By moving inward, by convergence, but we cannot converge, or we want to relieve the convergence. So what will be the other alternative? We just simply bring the image, cause displacement of the image toward the eye. So the eye will be on the same primary position like this, and we are just moving the image to displace the image to be like in toward the eye in the primary position. So instead of the eyes, both of the eye will move inward, we are just moving the book outward. So it will reach to the eye in the primary position. How can we do so? By placing 2 bays in prism. If we are placing 2 bays in the prism, then what will happen? Then the light rays deviate toward the base, and then it will enter the eye, and the eye and the image then will move toward the apex. So the image of the book will be here, and it will be fused by the brain. So we brought the image of the book toward the eye, and instead we've bringing the eye toward the image of the book. So you got it now? This is the effect of the Bayes in prism. It will relieve the convergence by this mechanism. So once we do so, this will cause the patient's comfort. It will relieve his headache. It will relieve the eye strain, and it will relieve his tired eyes. Okay. I hope that this is clear. If anything is not clear, please let me know. Okay. So the next question will be based on maybe on the previous question. So we answered most of its elements. What is happens normally during the process of accommodation? So this will be covered in details in the physiology, but it's sometimes asked in the optics, sometimes asked in the anatomy. So what is the normal physiological processes that happen during accommodation? So in the accommodation will be relaxation of ciliary muscle. What do you think?
No.
No.
It will be contraction of the ciliary muscle instead. It will be decrease in the lens diameter.
No.
Yes.
Decrease.
No.
There will be, the lens will be bulging.
Increasing.
It will increase in the lens diameter. Will cause mydriasis.
No.
It will cause meiosis. Shallowing of the anterior chamber.
Yes.
Yes, because the iris is in front of the lens. So if there is bulge or increasing in the anteroposterior diameter, they will push the iris, or both the iris lens diaphragm will move forward, causing decreasing in the depth of the anterior chamber. The associated vertical deviation has no relation to the process of accommodation. Yes, that's correct. So excuse me?
Yeah, sir, could you please, sorry, we have already gone forward, but I'm a bit confused about the convergence thing.
Yeah.
Yeah, like why we have to relieve the convergence?
Because those patients are old. Like if you are expecting that those patients who have like 70-year-old or 80-year-old, they have no accommodation.
So we should induce convergence rather than relieving it, no?
If we are trying to induce, like we are putting an exercising prism, the muscles are weak, and the muscles cannot converge. Like, let me give you an example. This is the same thing that you are trying to put a book in front of the patient's eye who is presbyope, and he doesn't have any accommodation because his ciliary muscles are weak, and you are trying to make the ciliary muscle, you are training the ciliary muscle, you are putting the book in front of his eyes and ask him, try to read, and you should increase the power of your ciliary muscle. The ciliary muscle is weak. So I am at that level, I am relieving it, not exercising it. I'm exercising, like if we have an athlete in the Olympics, since the Olympics are running now, I exercise the athlete, making him more strong. But if I have like a patient who is weak and he has cancer and he is bedridden in the ICU, I can't exercise him. I want to relieve him. The same thing happens with the eye. Like if the muscles are very weak with this old age, like the ciliary muscle, I relieve it by putting a plus lens in front of it. If the medial recti are weak also with this age, and they cannot contract and do convergence, I relieve them by putting a Bayes in prism. Because if I try to do the reverse, I will increase the problem, make the patients more complaining, more difficult for him to read, and will causing him more diplopia. You got it?
Okay, so in the question, we have to place the magnifying sphere and the prism basin.
Yes, exactly. So we already in the question, we already placed a magnifying spectacles because we only addressed one problem, which is the lack of accommodation and the lack of magnification. But we didn't address the other problem, which is the lack of convergence. That's what caused the patient's symptoms. So we need to address that problem by the Bayes in prism.
Okay.
Okay. Okay, so these are the what are the changes that happens with accommodation? There will be bulge of the lens, so there will be, as you can see, there will be increase in the anteroposterior diameter. But actually, let me tell you something, that the bulge in the posterior surface will be more than the anterior surface. So again, posterior surface will bulge more, resulting in increasing in the thickness of the lens, increasing in the anteroposterior diameter and in the axial diameter. And this will be a result of contraction of the ciliary muscle. So the ciliary muscle will contract, leading to relaxation of the zoniole. So this will be discussed in more details in the physiology. How could the ciliary muscle contract? This will result in relaxation of the zoniole, leading to that the lens will assume a spherical shape or more globular shape, causing increasing in the accommodation. Okay, the next question regarding refraction in children. Which one will be the most correct answer? Cycloplegia with atropine 1% of eye drops is essential to fully correct hypertropia. Is this true or wrong?
Wrong.
Wrong.
Why?
Right. True.
Why it is wrong?
Because fully correction is not required in all patients of hypermetropia.
Yes, I'm very happy that you say that. Does the question is saying that you need to fully correct hypermetropia in all patients? No, the question didn't say that. The question is asking whether, if you want, just in case you want to fully correct hypertropia, do you require atropine 1% in order to fully correct hypertropia or not? So the question is not asking you about the purpose or when will you do full correction of hypertropia. They will ask you about the method of doing a full correction of hypertropia. You got it? It's asking about the method, not the purpose. So if you want to fully correct hypertropia for whatever indication you want, can you do so without atropine 1% for full cycloplegia in children? This is important. The answer is no. So actually, this is a totally correct answer. If you want to do refraction in children, like if the children, for example, have infantile have accommodative esotropia, and you want to fully correct the hypertropia, then you need to do, or you put atropine 1%. The question again didn't say that it is required in all patients. It didn't say that you need to fully correct hypermetropia in every patient. No, it is not like that. It is just asking about how would you do full correction of hypermetropia in the children. So this will be done by atropine 1% to do cycloplegia to reveal all accommodation that this child has. Okay, the next question may be a little also more tricky. Initial overcorrection of myopia will help to control the intermittent exodeviation.
False.
Wrong.
No. No.
Okay, so the rule for myopia is that if the patient has myopia, what we will do? We will do just
under correction.
Under correction, the least minus. Yes, I agree with you. But is this without exceptions? Actually, no, they have exceptions. Actually, I am just, this is just weird that these questions appeared in basic exam. This should be like clinical questions. So one of these exceptions is those patients with intermittent XT. In those patients with intermittent exotropia, those patients has a problem in their fusion. Let me just explain it in like, do you see this whiteboard?
Yes.
Can you see this whiteboard? Okay.
Yes.
Like if the patient has those patients or those both eyes, they have what is called the fusional versions. I just mentioned something about it before, like why when we have like this flower, why you see this flower single? Because they will be lies in the fusional versions of, let me just make this in another color. Because this flower like in the fusional versions of the right eye and in the fusional versions of the left eye. So this fusional versions between both eyes with what will cause that this image of the flower is seen as single, not as double image. So this is term of there is horizontal fusional versions, there is vertical fusional versions, there is cycloversions. So we discussed that before, and we will cover it in the binocular vision. But let's see what happens if one of the eyes is not well aligned. Like for example, what happens if one eye, if like the eye has XT or exotropia, like they are looking outward and the other eye is well aligned, and we still have the same flower here. Well, what happens is that the eye will be in the fusional versions of one eye, but it will not be within the fusional versions of the other eye. So this what will result in diplopia. So how can we try to improve this intermittent exotropia? This can be done by several methods. First of all, correction of the refractive error. So we want to just save this eye, save the fusional versions of this eye before that this intermittent problem change to constant, because if it is changing to constant exotropia, then because we didn't train and we didn't improve the reserve or the fusional reserve, then the problem. Would you please just mute yourself if you have like some noise at your place? If we have, if we didn't catch this eye, we didn't train this eye that has intermittent exotropia to be constant exotropia, this will result in the problem will be constant, and eventually this patient could need surgery for this constant exotropia. So how can we train this eye? How do we improve the fusional versions? We need this eye to move inward like this in order for this flower to return again within the fusional versions between of the both eyes. So how can we do so? Well, we have this magical solution of training the medial rectus muscle, inducing convergence, so that if we are just training the medial rectus here, we are just making it more strong, then this medial rectus could contract and leading to well alignment of the eye. It will just make the eye in the well alignment position again and control this intermittent exotropia. So the question again, how can we train or how can we stimulate this medial rectus? By stimulating the near reflex. If we are stimulating the near reflex, then we are just stimulating the accommodation, and the accommodation will stimulate convergence. So how can we stimulate accommodation? Usually those patients with intermittent exotropia, they usually have myopia. So it was found that one of the successful measures to control, to overstimulate this accommodation is to make the patient is slightly over minus, like by 0.25 diopters, by 0.5 diopters. So these patients will try to accommodate to overcome this over minus, and consequently, this over accommodation will stimulate the convergence, leading to control of this intermittent exotropia, making him the comprehension of diplopia will improve, and may eventually this patient will not need surgery, and the condition of his intermittent exotropia will improve with time. If it is, this was one of the initial measures, like this is not like a permanent solution, but it is sometimes helpful to control the problem and prevent the progression in order to avoid the surgery. So this is what is meant here in the question by the initial overcorrection of myopia may help to control the intermittent X deviation. You got it? So as I told you that this is usually a clinical question, but for some reason, those with the ICO confuse between the clinical and what is basic.
Sir, if exo is constant, then over minus will not help, right?
Usually it will not help, but it also should be given as a trial. So it should be given as a trial, but usually it will not be helpful. So we will usually proceed with the surgery like a bilateral lateral rectus recession. Okay, so the third question, hypermetropia is only corrected if the visual acuity is reduced or this is like a missing answer or a missing question. But we will just, this is the first half of the question is just simple enough to answer it. Do we only correct hypermetropia if the visual acuity is reduced?
No.
No, so what are the other indications?
Asthenopia or
Like if the patient
Isotropia.
if the patient has esotropia, yes, that's correct. But if the patient has good 6/6 vision and no esotropia, do we still need to correct the hypermetropia?
No.
No other indications?
Relief accommodation.
What happens if the patient complaining of the headache? Like he has perfect vision, he doesn't have esotropia, but he is still just accommodating all the time because causing him headache and eye strain. So again, we needed to address his hypermetropia. Okay, so the next one, we told that before. Astigmatism can be initially undercorrected to aid the tolerance of the new glasses.
True.
True.
True. Yes, this is one of the tricks that we needed to do for the astigmatism. So correction of the astigmatism should take into consideration the age of the patient. So the more older the patient, the less tolerant to the astigmatism correction, and the less tolerance to overcorrection, and the less tolerant to the change in the axis of the astigmatism. So we try to undercorrect, like if the patient has astigmatism of like -4 or -5, it is not a wise decision to give them these patients the whole -4 or -5 astigmatism initially, because this will make the patients intolerable to the glasses. So we just try to be more as accurate as possible with the axis. We try to undercorrect the power as much as possible to help them tolerate the new glasses. Okay, finally, the off-axis errors of prescriptions are rare in the cycloplegic refraction.
More. They are more.
They are more. And why they are more? What is that? What is this word? Aberrations, yes. So we are doing cycloplegic refraction. We are just increasing the spherical and the chromatic aberrations, and which will make us like inducing some kind of astigmatism that the patient doesn't have initially. And we are just scooping or sweeping in front of the patient's eye with the retinoscopy. We are just screening another axis, and we are just confused because of the presence of aberrations. So the off-axis errors are more in the cycloplegic refraction than in the narrow pupil refraction. So cycloplegic refraction is mandatory to obtain accurate retinoscopy in infants and children. And it is absolutely essential for all cases of strabismus. This is because of the relation of the accommodation and the convergence. So when we have a patient that have strabismus, there is a relation between the convergence and the accommodation. So we need to release the accommodation in order to measure the accurate angle. And this can be classically and the best is to be done with the atropine sulfate 1%. But we need to watch out of the adverse reactions of atropine. And in older children, we can use the cyclopentolate or homoatropine. And the proper cycloplegic refraction is necessary for management of the refractive accumulative esotropia particularly. When we are measuring the astigmatism, we want to detect the axis of the astigmatism. This can be done by scooping or sweeping the retinoscopy streak against the patient's eye. So we need to align the light outside the pupil to the light inside the pupil. If we have this break, this is what's called break, then we need to change the axis of the light streak in order to be in line with the light inside the pupil. If we still have this break, then this will to what we call the off axis. We are not on the same axis of the pupil. So what happens if we dilate the eye? When we dilate the eye, when we have like small eye like this, it is usually easier to get the correct axis because the light inside the pupil will be on line with the light outside the pupil. But when we are just dilating the pupil like this in cycloplegic refraction, this will induce some sort of aberrations. And these aberrations may cause that the light reflex doesn't seem as clear as in the small pupil, making you more liable to do off-axis. This is one reason. Another reason is that when you are doing retinoscopy of a small child, you are usually those like a 1 year or 2 year child, you are not putting a trial frame in front of his eyes. So there is no trial frame. You are just holding a free lens in front of the eye. So if you are not just very well aligned in front of his eyes, then you are not sweeping the central part of the eye, but you may be a little bit peripheral. When you are little bit peripheral, you are not refracting the central part of the eye. You are most likely to be off axis, to just refract another area or another peripheral part of the cornea and the lens, leading to you are just inducing a new astigmatism. This is what's called spurious astigmatism. So you need to make sure that you are well aligned, especially if the patient has dilated pupil, and if you are using you are holding lenses in rather than using a trial frame. Okay, let's check the next question. Regarding the spectacle lenses, which one of the following statements are true and which are false? Executive bifocals are free from prismatic jump or image jump. What do you think? So I don't think that you already read the bifocals, because this question. Okay, so I was very skeptical about this question. Like when I see this word free, I just become very skeptical. I doubt a lot. So I referred to the Elkington, and the Elkington said clearly, with no hesitation and with no doubts, that the executive bifocal have no prismatic jump. Full stop. So I don't have doubts anymore. Like since Elkington said clearly that executive bifocal have no prismatic jump, then it has a reason, because that the optical center of the reading part is on the dividing line, so there is no prismatic jump. So if you didn't check the bifocal lecture, just refer to that. Okay, so looking through the non-central part of the spectacle lens give astigmatic aberration.
Yes.
Yes, exactly. That's correct. It will give what's called the oblique astigmatism aberration. Change in the lens shape can reduce the chromatic aberration. The lens shape.
False.
So how can we correct the chromatic aberration?
Spherical aberration.
Yes, exactly. The changes in the lens shape will reduce the spherical aberration, not the chromatic aberration. Like to make the lens aspheric, to make the lens has the flattened periphery. That is how we change the lens like this from one form to making it like this form, which will be like flattening of the periphery will reduce the chromatic aberration. But it is the change in the lens, let's say design or lens refractive index that will reduce the chromatic aberration, like using a chromatic doublet. Negative cylinders on toxic lenses have less meridional magnification than cylinder. I didn't understand this sentence very well, so because I think that there is something wrong with this sentence. It is just a recall question. The meniscus lens is the best form for myopic errors greater than 20 diopters. What do you think? It's true. The meniscus lens is always the best form lens. Whether they are myopia or hypermetropia with small or larger error, the meniscus lens, which consists of one plus surface and one minus surface, will be the best. Okay, so the executive or full field bifocal lens, they have like a near segment to cover the entire lower segment, lower half of the eye. They have this optical center. The optical center is present on the dividing line between the distance portion and the near portion, and that's why there is no image jump or there is no prismatic jump. So if you just didn't reach that part, well, when you are watching the video of the bifocal lens, it will be covered in more details. The oblique astigmatism is a kind of a peripheral aberration that happens when we are not looking centrally through the center of the lens, but peripherally, as you can see here, we are looking through the peripheral, leading to, even though we are using a spherical lens, this peripheral part refraction, it will be like a cylindrical lens. It is making a conoid of Sturm, resulting in an oblique astigmatism. This is how can we correct the chromatic aberrations by using achromatic doublet, like using lenses from different refractive indices like crown glass, a plus lens from crown glass, a minus lens from the flint glass, so that they will neutralize the chromatic aberrations of each other. So this is the principle of the lenses used in professional cameras are based on. And this is the difference between the chromatic and the spherical aberrations. So if how to decrease the spherical aberrations, we change the lens shape. So changing the lens shape, like using aspheric lenses with the flattened periphery, this is what will decrease the spherical, not the chromatic aberrations. Okay, next question. Just drink a cup of water. Okay, regarding the refractive error, which one of these statements are true and which are false? A person aged 40-year-old has an amplitude of accommodation of approximately 10 diopter. This is true or wrong?
No.
Yes, because if it is true, we wouldn't have any presbyope patient, because a patient with or anyone with 10 diopter accommodation can read up to 10 centimeters upward. So this is not true. Actually, those patients with 40 years have around 4 diopters of accommodation. And this is when they are starting to complain. And a person age 60 would have a near point of around plus or minus 1 meter. So this means that he has around 1 diopter of accommodation, plus or minus. Is it true or wrong?
Correct.
Correct, yes, that's right. In an isometropia of 1 diopter in children shouldn't be fully corrected.
Should be correct.
So if we do have a child with just a difference in one diopter with anisometropia with more,
Should be
so
correct.
it should be corrected. So if we left him, this is wrong.
It's false.
Wrong.
Um,
False.
Yes, wrong.
So let me ask you, and why it is wrong?
But
Plus one
isometropia
hypermetropia.
will
It will cause
That's
anisometropia or
amblyopia. It will call amblyopia.
plus one hypermetropia.
Okay, so I just brought you a table. I don't remember if I just place it. It is present in one of my lectures. Just hold on. I will bring it to you. It is present already in the October 2020 course, which is the require or the indications of
Up till 4 should be corrected.
just hold on.
Yes, should be corrected.
Okay, so let's say that if we have difference anisometropia between both eyes around +1 diopter, the question is if it will be shouldn't be fully corrected. Well, it will be wrong. It should be wrong. That it should be fully corrected, but actually could it be left, or it could be in all patients? Then the question didn't ask or didn't say that we should correct it in all patients, or it could be under corrected. So this is what I want to stress on. This will depend on whether the patient has strabismus or not, if the patient has amblyopia or not, if the patient has hypermetropia or myopia, and what is the grade of hypermetropia and myopia. This patient who had one diopter difference, it could not be fully corrected. Meaning that if you are just check the October 2020 optics course, you will find a question that I presented a table recommendation by the American Association of Pediatric Ophthalmologists, stating which condition requires a correction depending on the age of the child and the amount of error and the complaint whether there are strabismus or not, and whether there will be myopia or hypermetropia or not. You will find that in this table that no indication, or there is no indication for a correction of one diopter, all above one diopter. So if for cases of anisometropia without amblyopia or without strabismus. So I just I put it yesterday, but it is not here today. If you can just refer to this table and I can send you to the group. So this means that it is not a must. That I want to stress. Shouldn't be fully corrected. It should be corrected, yes, in some cases, but it could be not full corrected in some cases, in some other cases. So this depends on many other factors. So and you may think, why? But this anisometropia will cause the patient anisoconia. Here is the thing. The answer of option C is answered in D. In anisoconia, the tolerable amount or the tolerable limit of difference in the retinal image size is 5%. Yes, this is true.
Yes.
And a 1 diopter difference between both eyes is within the limit of 5%. A 1 diopter between both eyes will cause around, like, every 0.25 diopter will cause like around I think as far as I remember that 0.25 diopter will cause difference of 0.5%.
0.5.
So if we have one diopter, then this will result in 2% difference. And 2% difference is within the limit of 5% difference. So that's what I'm telling you. If I have a child of like -3 in one eye and -4 in the other eye, they have one diopter difference. So if there is anisometropia, does this means that I need to fully correct? Doesn't have always to be like that. Like one diopter is not always an indication for full correction, depending on many factors. But so actually my objection for this word, it is the word should. If it is could rather than should, I will agree with that. But since it is mentioning shouldn't fully corrected, so I will disagree. So I will say that it is false. I hope that you get my meaning. So this is how I would think this question, how I would approach it. Okay, the last sentence in the Ephikia, the anterior focal point is closer to the cornea, rather than the Ephikia. Is that true? Actually, no, because in this is actually about the distance of the F1. So F1 in the case of Ephikia, it is about 15.6 millimeter, while in case of the Ephikia, it's around 24 millimeters. So the anterior focal point is more far in Ephikia more than Phakia. Okay, so here is the table that will show the amplitude of accommodation depending on the age. So we are born with a large amount of accommodation, and as we get older, with our eyes tend to increase in the axial length, and this is compensated by decrease in the accommodation. So like around in 10 age of years, the accommodation is around 14 diopters. As we get 40, then the accommodation is around 5 to 4 diopters. As we get 60, the accommodation is around 1 diopter. By the age of 75, there is no accommodation left. And as we mentioned in the anisometropia and the anisoconia, each 0.25 diopter of difference in the refraction between two eyes, it will lead to 0.5 difference in the retinal image size, and the maximum toleration is 5%. So this is so that's why we are usually correct the accommodation, the anisometropy, if it is 2.5 diopters, but this is more for the myopic side. But if it is for the difference in the hypermetropic side or the astigmatism, we are less tolerant than the myopia. We can correct up to 1.25 or 1.5 difference between both eyes for the astigmatism and the hypermetropia to avoid amblyopia and for the sake of development of normal binocular vision. The difference or the distance of the F1 or the anterior focal point is 24 millimeters in case of the Ephikia, so it is more far from the cornea rather than the normal phakic eyes, like which we know the F1 from the schematic eye. So the first focal point in the schematic eye is 15.7 millimeters, and this will be much closer to the cornea. Okay, so let's move to the next question. Regarding astigmatism, which one of the following is true and which is false? With the rule astigmatism indicating that the axis of the negative slender is 90 degrees. If we have with the rule astigmatism. Yes, exactly.
False.
If we have patients with the rule astigmatism, this means that the vertical meridian is more powerful than the horizontal meridian. And if we place a negative slender at 90 degrees, so this is like a minus lens with 90 degrees, what will happen that this 90 degrees, this minus lens present at 90 degrees will weaken the perpendicular meridian, which is the horizontal meridian, causing like, and this will not be, in this case, will not be with the rule astigmatism. So with the rule astigmatism, meaning that the vertical meridian is more powerful. And in order to put a negative slender over it, then we should put the negative slender at 180. So that when we are putting the negative slender at 180, it will weaken the vertical meridian, which is already strong. Or the reverse, we can put a plus cylinder at the 90, so it can strengthen the horizontal meridian, which is the weak meridian. We will discuss this in more details in the next slides. Oblique astigmatism can be corrected by the appropriate spherocylindrical lens. Is it correct or wrong?
True. Right.
Right, so, but it is oblique. Can we still correct oblique astigmatism with a spherocylindrical lens?
Contact lens will be better.
Contact lens will be better. Okay, we will just focus on that, on the sentence. Like the question is asking about oblique astigmatism could be corrected by spherocylindrical lens, so it is not on the vertical or horizontal meridian. Is it correct? Yes, it is correct. So
Yes.
don't be confusing an oblique astigmatism with irregular
Can-
astigmatism.
Can be-
Oblique
can-
astigmatism, it is still regular astigmatism and can be still corrected by the toric lens or spherocylindrical lens. So it could be glasses, could be contact lens, but it is still can be corrected. The circle of least confusion lies midway between the two focal lines.
Correct.
Yes, correct. It is the diopteric mid value between the anterior and the posterior focal lines, or the first and second focal lines, and that's why it's present in the middle. If we want to represent it in a number, it will be the spherical equivalent. So this is the diopteric mid value. Lenticular astigmatism in the eye is small.
Correct.
Correct. So the most
Right.
astigmatism that the eye suffer from is corneal astigmatism. In compound myopic astigmatism, one focal point lies in front and the other behind the retina.
No.
False.
Also, what kind of astigmatism in which the one focal point lies in front and the other behind the retina?
Mixed.
It is the
Mixed.
Yes, that's
Yes.
correct. So when you have these questions asking about with the rule astigmatism and against the rule astigmatism, just in order to answer these questions, keep in mind the two rules. What is with the rule astigmatism? It is which in the vertical meridian is much more strong. And what is the against the rule astigmatism, in which the horizontal meridian is more strong. So in this eye, which one is does this eye has with the rule astigmatism or against the rule astigmatism?
With the rule.
So you can see that the red, which is the vertical, making a focus behind the retina, and the blue, which is horizontal, making a focus in front of the retina.
In
ATR.
front of the.
ATR.
It is, yes, it is ATR, or the against the rule astigmatism. Like if we want to give them numbers, like a keratometric reading, when we are just measuring the power of this cornea with autorefractometer or keratometer or pentacam or any device that measure the corneal reading. This can be, for example, like the vertical meridian will be like 40 and the horizontal meridian will be 44. So 44 is the horizontal meridian, which is more powerful and causing it will be more myopic, making a focus in front of the retina. The 40, it is less powerful, making the vertical meridian more flat, making a focus behind the retina. So the difference between both of them will be 4 diopters. And these 4 diopters are the amount of astigmatism that this patient has. So how can we correct this 4 diopters of astigmatism? Since this patient has against the rule astigmatism, we can just placing a +4 diopter in axis
180.
180 or
minus
place
4,
-4 diopter
90.
this is 90. So if we are placing +4 diopter at 180, this will cause more strengthening of the vertical meridian, correcting the against the rule astigmatism. If you are putting -4 at the 90, it will weaken the horizontal meridian, causing correction of the against the rule astigmatism. Okay, we will need this in another question. The second rule that you need to put in mind that basically the principle of the cylindrical lens, that the cylindrical lens are only curved at one place or at one surface, which is curved in the horizontal meridian, leading to that the maximum power will be 90 degrees from the axis. So in this cylindrical lens, this has this vertical axis. When the light rays hit the cylindrical lens in the horizontal axis, they will make a focus because it will has a refractive power. This refractive power, if the light rays are hitting the lens perpendicular to its axis. But if the light rays hitting the lens parallel to its axis, they will be parallel. It will act as a plate of glass. So it has zero power perpendicular to the axis. That's why we are saying that if we are placing a -4 lens at 90 degrees, it will correct the 180. If we are placing the 4 diopter at 180, it will correct the 90 degrees, because this is the principle of a cylindrical lens. The astigmatism can be divided according to the meridian into the vertical, horizontal, and the oblique. Still note that the oblique astigmatism is a regular astigmatism, because the two principal meridia are 90 degrees to each other, which means that it can be normally corrected by toric lenses simply without any problems. The circle of least confusion, it is the dioptric mid-value between the anterior and posterior focal line. This is the correct. And for the different kinds of astigmatism, the compound myopic astigmatism, the two focal points are in front of the retina, while in the mixed astigmatism, there is one focal point in front of the retina, and the second one, or the posterior one, is behind the retina. Okay. Regarding another question regarding the myopia. Which one of the following statements are true and which are false? The far point lies at infinity when the accommodation is relaxed. This is very simple, very basic question. What do you think?
Correct. Correct.
True.
Correct.
It's correct or wrong?
Wrong.
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 Far point lies near.
So when the eye is completely relaxed, if the far point will be at the infinity, do you think this pattern is what happens in the myopia or the emmetropia? This is the emmetropia. When the accommodation is totally relaxed, the far point is infinity. But what happens in the myopia? When the accommodation is relaxed, the eye, the refractive system of the eye is much powerful. So it will bring the far point or the punctum remotum into a point in front of the eye. So it is the far point is in front of the eye in case of myopia. It is a virtual point behind the eye in case of hypermetropia, and it is infinity in the emmetropia. This is all in case of the accommodation is relaxed. Myopia may have meant that presbyopia spectacles are never needed.
Wrong.
What do you think?
Wrong. Never.
It depends on amount of my.
Yes.
Hello, can you hear me?
Yes.
Yes.
Hello,
Yes.
do you hear me?
Yes. Yes.
Yes.
Yes, we can hear you.
Hello, can you hear me?
Yes.
Yes. Yes.
Sorry,
Yes. We can
I
hear you.
got disconnected. So I was asking about the second question. Can you please tell me what's your answer?
Wrong.
Wrong. Wrong.
So like let's say that if a patient has like -6 diopters or -10 diopters, do you think that after 40, like if he is 60 or 70 or 80, does he need spectacle for presbyopia?
No.
Yes. He needs
Yes,
under
needs
correction.
delayed, but
Needs
needs. Yeah.
weak, like -6 leads -4, like minus like
Okay,
that.
I'm saying that if he has like -10 diopters, it is saying that myopia may, like if he has high grades of myopia,
Mm.
so you are still giving him a presbyopic spectacles at older age.
Can be given.
Are never needed.
The question is saying that if a patient has myopia, he may not need presbyopic spectacles, depending on the amount of myopia that he may have. And actually, this is true. If a patient has like if a patient, in order for a patient to read, he need 4 diopters of active accommodation so that he can read at 25 centimeters. If a patient who already has like 10 diopters, why would you give him extra 4 diopters? He already can read at 10 centimeters. So he can read at 10 centimeters, at 20 centimeters, 25 centimeters. He already has a very good myopic reserve. And this is what we call the second sight. Second sight meaning that the patients who have myopia, who have been wearing glasses their entire life, may be independent from the glasses after the age of 40, because they already have myopia. See, it compensated for the hypermetropic shift that happens after the age of 40. So depending on the degree of myopia, like if they have -1 or -2 or -3, they may need presbyopic spectacles at some point within their life. Maybe it will be a little bit delayed. Maybe they need it at 50 years or 60 years. But for more myopia, like for -4, -5, -6, they may not, as the question is saying, they may not need this presbyopic spectacles may are never needed or never needed because he already have high myopia. So you got my point? Does anyone disagree, or does
The
anyone
question
have
doesn't say high myopia.
Yes, but it's saying the myopia, this term
The
will
main
cover
word
all.
is may.
It didn't
May
specify,
have.
and the question didn't say it will must, it say it may. So it gives you the possibility that this can never be needed. So is this possibility is present in any case, in generally speaking about myopia or not? So again, I'm telling you, watch out the language. It is just asking you about the possibility. May indicates a possibility. If it is 1% possibility with this term, then the question will be true. Is there any possibility that a patient who had myopia, regardless of the amount of diopters, will never need presbyopic spectacles? Is there any possibility?
Yes.
Yes. So the question is true. Most cases are due to axial myopia.
Correct.
Correct, that's right. So it's more than the refractive myopia. Myopia can occur only due to changes in the lens.
No.
No.
Can occur also changes in the cornea. Myopia
Yes.
is decreasing in the dark. So this will be covered in the physiology.
Yes.
Increasing in dark.
It is increasing. There is what's
Yes.
called the this is not true. There is what's called the night myopia. This will be discussed in the physiology. During the night, we are just the pupil is dilated and the eye can't see because of the target. So the eye assume that there is a target that they cannot see and they try to accommodate on it. So this more tendency to accommodate at night will causing more myopic shift, causing more myopia in the dark. Okay, so this is one of the changes that happen to the eye in the dark. We will cover them in the physiology. Okay, so this is the myopia and this is the punctum remotum. The punctum remotum in case of myopia is in front of the eye, and so other options are already explained. Another question about myopia regarding the prevalence and the risk factors of myopia. So which one of the following statements is true and which is wrong? The prevalence of myopia may be significantly influenced by the outdoor light.
Yes.
Yes, exactly. Increasing exposure to outdoor light, like it was found to be a very simple and effective measure to decrease the myopia, to prevent the progression of myopia. So the more exposure to outdoor light, the less the myopia. Myopia is more common in females or in males? It's more common in females, right?
Male.
Yes, it is
No.
more common. It's more common in females. In highly developed societies, genetical factors are less important than other factors.
Yes.
Correct.
So this means that in the, let's just think of
False.
correct or false. Let's think of it like, does this question mean that in less developed countries, the genetical factors are more important than other factors? Or in the less developed countries, the other factors are more important than genetical factors? So this is how would I think about it. Like, we know that there are some genetical factors regarding the myopia, and we also have, there are other factors, like for example, the use of electronic devices, like mobile phones, like iPad, like whatever. So the use of these electronic devices, the constant near work on computers and laptops is also what are causing the increasing the myopia, and that's why the outdoor activities will decrease the myopia. So in highly developed countries where the electronic devices are more prevalent, is this mean that the genetical factors are less important than the other factors?
No.
I don't think so. Maybe if it is saying that in the less developed countries, the genetical factors are less important than other factors, or more important, then they will have some rationale. But since that it's asking about the highly developed countries, I will relate this to the other factors. It will be not, I won't say that the other factors are more important, but at least that they will be as important as other factors. So I think that in highly developed countries, other factors as important as the genetical factors as well. And these genetical factors are not only assigned to a specific society or certain category of societies as highly developed or less developed. Myopia is prevalent in those who have received a postgraduate qualification or postgraduate.
No.
You're wrong.
Because they tend to study more, they tend to do more close work, so they have more myopia. prevalence of myopia is similar in early, conventionally, if prematurity. So this question is missing some answers. But I believe that it is asking about the prevalence of myopia in those patients with retinopathy of prematurity. So is the patients with retinopathy of prematurity have any higher incidence of myopia? Actually, yes.
Yes. Yes, they have.
Because first of all, anatomically, they are different. They are different anatomically from the normal eyes. The second of all, the treatment itself can induce myopia. Like those patients, when they are receiving laser, this laser can be hitting the long ciliary nerves, which are supplying the ciliary muscle. They showed that those patients that receive the laser have more tendency to develop myopia when they get older. So prevalence of myopia is higher in patients with retinopathy of prematurity. Okay, so let's move to the next question. So this question is asking about the characters of image reflected from the cornea. So we know from the Purkinje Sanson image that the first Purkinje image is reflected from the anterior corneal surface, which act as a convex mirror. So what is the characters of the image reflected from the anterior surface of the cornea, which act as a convex mirror? This will be discussed again in the keratometer lecture in the instruments, but I thought to bring it here because actually it's asking about a simple rule or a simple characters of the image reflected from a convex surface that we already discussed in the early lectures. So which one of those will be the true answer? There's only one answer. Is it A or B or C or D or E?
E.
Note that the question is asking about the image reflected from the cornea. It doesn't ask about the
E
level
is
of
right.
reflection. It's asked about where the image is formed.
Okay.
E.
The correct answer is B. It is an virtual, upright, magnified, and behind the cornea. This is the same like reflection from any convex surface. If we are convex mirror, if we are placing the object here, and just to draw the rays, there will be a ray that will parallel to the surface and it will reflect away from the convex mirror. This is a convex mirror. So its extension will pass through the focus. And we have another ray that will pass through the, let's say that, just to draw it again, or use the whiteboard. If we have a convex mirror like this, and we have an object like this, so how can we know the characters of the image formed by this convex surface? So if we have a parallel rays to the principal meridian, then it will reflect from the convex surface like this, so that its extension will pass into the focus. If we have another ray that like passing through the center of curvature, this is center of curvature, it will reflect on itself. So the image is formed at the point of intersection of rays, so it will be here. It will be behind the mirror. It will be a virtual because it's formed by the extension of rays. It will be upright. So this is the arrow. It will be magnified. It's upright, magnified, virtual, erect, behind the mirror. So let's get back to the question. It will be virtual, upright, magnified, and behind the cornea or behind the convex mirror. So other options are all wrong. So The cornea, as we mentioned, it is acting as a reflecting surface and as a convex mirror. So these are the how is the convex mirror is doing. It doesn't show any other options. It will be only a single condition for whatever the distance of the image in front of the convex mirror. It will always give a virtual erect magnified image behind the anterior corneal surface. And this is the principle of the keratometry. Okay. Okay, so let's now check the next question. So which one of the following keratometric readings is against the rule? So here, please bear in mind that it's asking about the keratometric reading. Like if we have an autoref, an autorefractometer, and we have the values of the autorefractometers, what will be the keratometric readings that will give an against the rule? So the first one will be wrong because there is no astigmatism at all. It is 0 power at 0 astigmatism. And the second one, again, it will be there is no astigmatism at all. There will be 0 power at 180. So what about the third one?
Right.
Is right. Yes, exactly. This means that the 180 is corrected by +2. So it is +2 at 180, meaning that the 180 is more powerful by 2 diopters than the 90. Then this means that it is against the rule. The third one, or the +5 at 120, this is wrong.
It's wrong.
It is oblique astigmatism. +5 at 90,
Wrong.
wrong. This is with the rule astigmatism. So to understand how a keratometric reading looks like, this is the simple autoref, autorefractometer. So you can see that these are the keratometric reading. R1, or the first keratometric reading, or the one of the two principal meridians of the cornea, has a power of 43 diopter at axis of 172, which is against the rule. It is mean that this power is at the horizontal meridian. The second one, or the second principal meridian, or R2, has a power of 43.75, which is more strong, at axis of 82, which means that it is with the rule. So we have one meridian, which is more powerful at 90 degrees, or with the rule, and another meridian, which is less powerful, which is against the rule at the horizontal meridian. Then the difference between them is 0.75 diopter. So the slender is minus 0.75 diopter at 172. So if we are just putting the horizontal meridian, which is the 172, is weaker by 0.75 diopter from the vertical meridian, which means that the horizontal meridian is weaker than the vertical meridian, meaning that this patient had with the rule astigmatism. So the vertical meridian is strong, the horizontal meridian is weak. The difference is 0.75 diopters, and it is by minus on 172. If we want to change it to the plus, then it will be plus 0.75 in the 82 degrees. So you got it now? You see what is the difference between the with the rule and the against the rule? Okay, check the next question about the cross cylinder. Okay, so regarding the following statements regarding cross cylinder, which are true and false, the sum of the cylindrical power is 0. Focus on this question very carefully.
It's
True.
true.
Think. If it is the
Spherical
sum,
spherical power.
Yes, exactly. The spherical equivalent of the cross cylinder is 0, but not the cylindrical power. If we want to say that the patient has a cylindrical power is 0, then the two cylinders should be at opposite signs, which is true if they are opposite sign, but they will also should be on the same axis. Like if we have a patient who had like plus 0.5 cylinder at axis 180, if we calculate it to minus 0.5 at 180, then the sum will be 0. But is this how the cross cylinder is built? No. The cross cylinder is built so that they will be different cylinder or the same power of the cylinder, but are on perpendicular meridian. So the minus 0.5 actually is here. So if we are just calculating, you are adding the cylinder to the same axis, like 90 or to 80, 180 to 180, but not 1 to 90 and 1 to 180, because this is not how the cross cylinder is built. If it is just the cylindrical power is 0, so why we are using it? It will not be making any sense in the terms of adjusting the subjective refraction. But it is used because it is the spherical equivalent is 0, not the cylindrical power is 0, or not the sum of the cylindrical power is 0. Okay, so they are usually available in 0.5 diopter sphere and 1 diopter sphere power.
No,
No, so what is the true?
0.5 and 0.25.
Well,
0.25, 0.5.
the cross cylinders, this will be the amount of astigmatism, but they are, yes, I agree that it will be 0.25 and 0.5, but actually this is the cross cylinder is named after the power of the cylinder, not the power of a sphere. So we have two kinds of sphere, or sorry, no, two kinds of cylinder. 0.5 cylinder will give rise to the cross cylinder of 0.25, and the 1 diopter cylinder will give rise to the 0.5 cross cylinder. So it is termed of the amount of cylinder that we will use in this cross cylinder, because note that it is a spherocylindrical lens. So the wrong here is it is the use of the diopter sphere rather than the use of the number or the figure. Clinically, the cylinder axis is checked before the power.
True.
True. We said that A before P in the alphabet. So A axis is before the P. It is best to use the forced choice technique.
False.
So we are just giving what, and let me just explain what is meant by the forced choice technique. Like when you are placing the cross cylinder in front of the patient's eye, you ask him specifically if a choice number 1 is better or number 2, like lens number 1 or lens number 2. The patient sometimes they may tell you that, well, without the lens is better, but you don't give him this option. You force him to choose whether option number 1 or option number 2. This is what's called a forced choice technique. You just give the patients two options, lens number 1 or lens number 2, and he only need to choose between one of them, because in most of cases both of them will be worse than without a lens. So the patient, if the patient has very correct subjective refraction, and then he may see the both of lenses will be worse, and he can see clearly without any one of them, but you force him to choose whether lens number 1 or lens number 2, or they are both equally the same. So this is like a forced choice. You are not giving him multiple options, you are just giving him very limited options in order to choose between them. It doesn't degrade the vision of an amyotropic eye if placed inside. So this is like missing answer. Doesn't make any sense. So we are going to skip that. So the cross cylinder, how it is made, it has a spherocylindrical lens that have spherical component combined with a cylindrical component. This cylindrical component is twice the sphere. So it is twice the power of the sphere. And this half of power of the sphere, so it can be like plus 0.5 diopter sphere combined with 1 diopter cylinder. This will result in 0.5 in one meridian and plus and minus 0.5 in the other axis. So this will give rise to the 0.5 cylinder. This 1 diopter cylinder is how we name the cross cylinder. So we say that this cross cylinder is 1 diopter cylinder, which will give the two lenses 0.5 each. Or we can use the 0.5 diopter cylinder, which will give rise to the two lenses 0.25 diopter each. You got it? In each way, or in either way, the spherical equivalent will be always 0. Regarding the calculation or adding the powers of the cylinder, so this is like using a spherical lens of plus 0.5 and using a cylindrical lens of minus 1 axis 90. This will result in just you add only the similar axes. So adding plus 5 to minus 1, giving minus 1 at one axis, and adding plus 0.5 to 0 will give the plus 0.5 at the other axis. So this is a cross cylinder. It has two cylinders of the same power, different signs, and perpendicular to each other. The same if we combine a plus cylinder of 0.5 at 180 and plus 0.5 at 90. So this should be 90. Sorry, this should be minus. So what will be the result? Minus 0.5 at 90 and plus 0.5 at 180. So it will be the same thing. Both of them will be the same. Okay, so you don't add cylinders on different axes. This is not correct. Okay, let's move to the next question. I know that this lecture is dense, as I told you. This is how optics are like. Okay, so the eye, the refractive index of the cornea is 1.37. True. The radius of curvature of anterior lens capsule is greater than the radius of posterior lens capsule. This is wrong. When the accommodation is relaxed. And why is that? So we will get that to explanation. Sorry, this is true. Let me just explain to you. When we have the accommodation is relaxed, the anterior lens capsule is more flat than the posterior lens capsule. So this is usually how the lens looks like. During the unaccommodated state, it is the exaggeration or the more bulge appear in the posterior during the accommodation state. So since the anterior lens capsule is flat or it is less curved, this means that its radius of curvature is more than the posterior surface. There is the radius of curvature is inversely proportionate to the curvature or the power. So R equals 1 divided by P. The more flat the capsule or the more flat the surface, the less radius of curvature. The more curved the surface, the less radius of curvature. So since the anterior lens capsule is flatter than the posterior lens capsule, then its radius of curvature will be larger when the condition is relaxed. So I will just give you an example for this inverse relation from the question of the radius of curvature, or from the questions of against the rule astigmatism that we just mentioned here. You can see this number in millimeters. These numbers, they represent the 7.87 and 7.73. These numbers are representing the radius of curvature. So when you see that the first one has smaller power, but it has more radius of curvature, The second number, 43.75, it has more power, but it has less radius of curvature. It is only 7.73. So there is inverse relation the radius of curvature and the power of the surface. The power of the surface is represented by the curvature. So the more curve, the more power, the less radius. The less curve, the less power, the more radius. You got it? The Helmholtz model of the eye has a single refracting surface. What do you think?
A reduced eye has single reflecting surface.
Excuse me?
Reduced eye, listing reduced eye.
It has double. It has it is the reduced eye has single refractive surface, and the Helmholtz has a double refractive surface. The refractive index of the reduced eye is 1.336, which is the same as the vitreous and the aqueous. This is correct. The first and the second principal planes coincides at the anterior lens capsule. No,
False.
they straddle the
The anterior
posterior
chamber.
lens capsule. So this is the diameter of the lens. You can see that the anterior surface of the lens, you can see this is the like unaccommodated, it is flatter. And since the anterior lens capsule is flatter, its radius of curvature is more, while the posterior lens capsule is small, is more curved, so it has less radius of curvature. The schematic eye or the Helmholtz eye has two principal planes, two nodal points, and two focal points. On the other hand, the reduced eye, it has one principal point, one nodal point, and the two focal points. Please note that the two focal points of the Helmholtz eye are straddling the posterior lens surface. So one in the lens and the other behind the lens. I told that in the lectures that the visual acuity and the contrast sensitivity are usually asked, can be asked in the physiology, but they are sometimes also asked in the optics. So I put them in the optics course as well in order for you to study it as well, but we will get to that also in the physiology. So regarding the visual acuity and the contrast sensitivity, the Snellen chart uses the Sloan letter set. So this is not true. There is difference between the Sloan letter set and the Snellen chart, as I am going to show you now. Okay, so the near vision should be tested at a distance of 0.5 meter or 50 centimeters. Is this true?
False.
False. We don't usually read at that long distance. Visual acuity decrease exponentially with eccentricity from the fovea. So exponentially meaning that it increases rapidly as much as we move away from the fovea.
False.
So it doesn't decrease?
It decreased, but gradually.
Well,
true.
Well, I will tell you something that exponentially it is like a mathematical term, but in this scenario, I don't believe that they meant the actual mathematical meaning of this term. Like this term meaning that has two scientific meaning or the mathematical meaning. Like 1 become 2, then 2 become 4, 4 become 8, then 8 become like increasing extensively or in a mathematical calculation. Or it can also be meaning that it is decreasing rapidly. So for this question, it will decrease rapidly and not gradually. And I'm going to show you now how is the difference and how is the rapid decrease from the fovea. So this could be, or this is considered a right option. Localization acuity or misalignment is typically a few seconds of arc.
Don't understand.
Well, localization acuity or misalignment, they are referring to it by the vernier acuity. If you watch the lectures, you will find there is a kind of hyper acuity. It's called the vernier acuity. And the vernier acuity, it meaning that the ability to detect any misalignment or displacement in the location of objects. So is this ability to detect this misalignment is only a few seconds of arc?
No.
True.
It is
No.
true.
True.
It's true. I will show you now.
True. True.
10 seconds of arc.
Yes. High frequency contrast sensitivity is limited by the optical factors.
True.
It is true. I will show also the explanation from the lectures. So actually, when you are seeing these questions, the problem is that you don't know where these options or how can I answer these questions, or how can I combine, like dig in the lectures and get the answers out of it. So this is what I'm trying to do here in these lectures, that I will just bridge the gap between the questions and the theoretical knowledge present in the lectures, helping you more to understand the questions. So the Snellen versus Sloan. So Sloan is not very familiar or very well recognized accurate chart, but actually there are difference between them. These difference are the kinds of letters used, the number of letters in each line. Like in the Sloan there is the same number of lectures, the same geometrical spacing horizontally and vertically between the letters, and the same height of letters, or the proportionate height of the letters. This is not the same as in the Snellen. So you can read the difference between both of them, but as the question is asking, is not the same. The Snellen are different from Sloan sets. So Sloan sets are usually used for research, like clinical research for the ETDRS study. Regarding the drop of the visual acuity from the distance of as we go away from the fovea. You see at the fovea, the vision is 6/6 or 20/20. But what happens if we are moving away from the fovea? This is for the retinal eccentricity. As we move even for like 10 degrees, like here 10 degrees, well, it will be like, you see, it will be like a huge decrease, huge drop of the visual acuity from just moving 10 degrees, from 5 or 10 degrees away from the fovea. So here is the 5 degrees, and here is at 10 degrees. Like at a 5 degrees, it will be almost like or near to the zero. So the actually, yes, the as we go away from the fovea, as we are more eccentric away from the fovea, the retina sensitivity or the visual acuity drops dramatically. Okay. So someone here wants to sleep.
Yes, sir. Sorry.
Yeah, I know that you are tired. Lecture is very tiring, I understand. So the minimum discriminable or the hyper acuity, it is the ability to detect a displacement in the line or displacement in the contour of the object. So this is what the question is asking about: localization acuity, the ability to detect this angle of displacement. And it was found it can be very sharp, our ability to detect this displacement, up to 2 to 10 seconds per arc. So this will be a high grade of and a high function of the visual acuity. That's called the minimum discriminable or the hyper acuity or the vernier acuity. So it can be a few seconds of arc, as the question is saying. The last question asking about the high frequencies, can be they limited by the optical factors? Yes, we said that we have some limitations of the contrast sensitivity. Some of them are extrinsic, like the outside light, and some are intrinsic. And the most important intrinsic is the refractive error. And what is the refractive error? It is optical factor. So optical factors such as refractive error can affect the contrast sensitivity. So in the start, they will affect the higher spatial frequency for mild refractive error. So for example, if a patient has -2, -3, or +2, +3, then at the higher spatial frequency, they may not be able to detect the alternating white and dark bands. And as the error become larger, as the degree of the refractive error increase, like plus 10, like minus 10, minus 20, even they will not be able to detect the middle and larger gratings, which indicates a lower spatial frequency. So even for higher errors of refraction, they will not be able to detect the middle to low spatial frequency. So you got it now? Let's get back to the question. Snellen chart uses the Sloan letter no. Near vision should be tested at 50 centimeters, no. Visual acuity decrease exponentially with eccentricity from the fovea, yes. Localization acuity or misalignment is typically a few seconds of arc, yes. High frequency contrast sensitivity is limited by the optical factors like refractive error. This is also correct. Next question about retinoscope. I'm afraid to tell you that we still have many questions left. So, okay. Okay, regarding the retinoscope, with a concave mirror, an image of the light source is formed in front of the retinoscopic pupil. This is correct or wrong?
Correct.
Yes, exactly. With a concave mirror, the image of light source is formed in front of the retinoscopic pupil. This is correct. With a plane mirror, the reflex of a myopia will always give against movement.
No.
No, exactly. It will depend on what is the degree of myopia and what is the distance between you and the patient. Positive spherical aberration will give a reflex that is brighter in the center of the pupil than in the periphery. So we didn't say that in the lectures, so I'm going to discuss it. It will be no. A scissor reflex can occur in the irregular astigmatism.
Correct.
Correct. When the reflex is neutralized, the far point of the subject's eye is located 6 centimeters in front of his or her pupil.
No.
So when the reflex is neutralized, where is the far point?
It is true.
Yes.
It's true. Yes, it is true.
True.
Will be you are standing in the far point of the patient. You are rendering the patient's myope of minus 1.5 diopters. So that's why they have the far point at the retinoscopy itself. So there are two kinds of positions of mirrors. We have the plane mirror effect and we have the concave mirror effect. In the plane mirror effect, we are moving in which position, when we are moving the mirror from one position to the second position, it will cause movement of the reflex. In case of plane mirror, it will be the same with the same movement. So it will move on the same direction. But in the case of concave mirror, it will be on the reverse direction. And in case of concave mirror, a real image of the light source is formed between the patient and the observer and close to the patient's eye. This is according to the Elkington. In myopia, minus 1 point diopter, if the patient has myopia minus 1 diopter and you are standing at 66 centimeters, then you will reach the point of neutralization. So it doesn't always have to give an against movement, because if the patient has myopia minus 1.5 and you are standing at a distance of 66 centimeters, then the patient's punctum remotum or the far point will be at the same location at the retinoscopy. You are making the patient or the patient's myopia will make a focus in front of his eyes by 66 centimeters, and you are standing now at this point. So you will reach the point of neutralization. So it is not always that every myopic patient will give against movement. If you are moving backward, if you are just moving backward, or if the patient has myopia of more than minus 1.5, then he will make a focus in front of his eyes. Then the lower rays will be up and the upper rays will be down. So you will see a reverse or an upside image of the red reflex, which means that there will be against movement of the red reflex. So if myopia more than minus 1.5, it will give an against movement. If the myopia is, so it can be corrected by a minus lens. Special difficulties in the retinoscopy. The retinoscopy is one of the challenging skills that you need to master. And one of the challenges is the presence of spherical aberration, especially with increasing the size of the pupil if you are refracting the dilated pupil. What is the effect of these spherical aberrations? This could be either negative aberrations or positive aberrations. The negative spherical aberrations, meaning that is the periphery is faint and the center is bright. So this is called negative spherical aberrations. The positive spherical aberrations, meaning that the periphery is shiny and the center is dark, or the center is more faint. So the center is faint is the positive spherical aberration. The center is bright is in the negative spherical aberrations. Scissoring or fish-mouthing reflex can be due to larger pupil-like aberrations, irregular astigmatism, irregular retina, tilted lens, corneal scars. So this is how does the scissoring reflex looks like. This is called the scissoring, which is very characteristic due to difference in refraction between the different parts of the cornea. A question regarding the contact lens. So I don't think that we covered the contact lens, but most of the options here are already covered in the lectures that you studied so far. So in myopia, there is increased retinal image size, meaning that if we are using a minus contact lens in myopia instead of spectacles, does this increase the retinal image size? Think of the lens effectivity. The lens effectivity, if we are moving toward the eye, if we are just using contact lens instead of spectacles, we are moving toward the eye, we are inside the F1, it will cause increase or decrease the retinal image size?
Increase.
It will cause larger retinal image size. Relative spectacle magnification in aphakia is 1. No, it will not be 1.
False. 1.33.
Yes, 1.3 in, it's 1.3 in spectacles, but in contact lens
1.1.
1.1 exactly. In hypermetropia, contact lens result in reduced requirement for convergence.
True.
Yes, it's true, because it will decrease in contrast to the glasses. The plus lenses glasses has a base out effect. The base out effect will increase the need for convergence. So since we are substituting the glasses with the base out effect with the contact lens, we are now removing this base out effect. Remember in the age-related macular degeneration question, use the base in prism in order to decrease the need of convergence. So because the base out will be the reverse, base out will increase the need of convergence. In contact lens, we are just using the contact lens instead of the glasses with its disadvantage of the base out effect. So this is like due to the prismatic effect of the periphery of the lens. A back toric lens is used for high corneal astigmatism. Well, this is true.
True.
Oxygen permeability increases with increased water content. This is also true. We will just get to that in the contact lens. So again and again and again, the effect of the back vertex distance on the retinal image size. When we were using minus lenses in myopia, which was at the F1, it was causing the image to be the same size. But if we are substituting it into a contact lens inside F1, we are the back vertex distance, they're causing the image to be increasing. So sorry, should be decrease. And this is increase. So the back vertex distance is increasing if we are outside F1. If we are inside F1, it will decrease. So the image size, the retinal image size increase if we changing from spectacle to contact lens. For the correction of unilateral aphakia, if you are using a spectacle, the relative spectacle magnification will be 1.3, while contact lens will be 1.1. The IOL will be the most suitable. It will be almost 1 to achieve binocularity. The effect of spectacle lenses on the convergence demands. You can see if we are using plus lenses like plus spectacles, this will result in that when the lens is converging, the lens is looking to a near target, then the lens is looking to, or the eye is looking through the lens periphery. And the lens periphery has a prismatic effect. In the plus lenses, it will be a base out. In the minus lenses, it will be a base in. So the base out will cause displacement of the light rays. It will cause displacement of the light rays toward the base. So the image will be displaced toward the apex. So it will cause more inward shift of the image, leading to that the eye is moving more inward in order to see the image, which is just displaced more in by the base out effect, causing the eyes to cause more convergence, increasing the convergence demand. The reverse will happen for the myopic lenses or the myopic minus lens. It will cause a based out reflex or based out effect, so causing the image to be shifted toward the apex, and the apex will be located further away from the eye. So the eyes will tend to do less convergence. So you got it now, that less convergence is required for spectacles in by the eyes using minus lenses, and more for the more the convergence is required for the eyes using plus lenses. This is for spectacle lenses because they have prismatic effect. We all know that in contact lenses we are avoiding the prismatic effects with all its problems, with its accommodation problems, with visual field problems, with convergence problems. So this is the difference between the spectacles and the contact lenses. Okay, a question regarding the subjective refraction. In determining the best vision sphere, a spherical lens should be made more positive only if the visual acuity increase. So when we are doing refinement of the sphere of the patient, if we only increase the plus sphere if the patient showed that there is increase in the visual acuity.
Yes.
No.
Okay, so this is wrong. This is wrong, not true. And I will show you now the rules for the spherical refinement. It will be to be made more positive if the visual acuity increase or the same. So if you are giving the patient +2 and then +2.25, and the patient says that it will be the same, we will give the highest plus. This is the rule. We give the highest plus or the least minus if you are giving the patient -1.75 and -1.5, and says that the visual acuity is the same with -1.5 with the 1.75, we will give the -1.5, which is more positive than -1.75. Although the vision is not increasing, but we are giving the more plus for the sake of relieving the accommodation. So this is the rule for the plus. For the minus, or if I just, when I give over minus of the patient, it is only if the visual acuity increase. So for the best vision sphere, the spherical lens should be more negative only if the visual acuity increase. It should be more positive if the visual acuity increase or if it is the same. You got it now? You know the rule now? The Jackson cross cylinder should only be used in patients with a spherocylindrical correction in the state of subjective refraction. If we only use a cross cylinder if we had like cylinder and the sphere got it by objective refraction, like by autoref or by retinoscopy. So if the patient has only sphere, we don't do cross cylinder.
We need not to do it, only sphere is
Is wrong.
So how can you make sure that this patient doesn't have any cylinder? It could be that the objective refraction was not correct, or it is not very accurate. Like your retinoscopy is not very accurate. Like the autoref is not very accurate. It showed the sphere, but the patient could have a cylinder and you didn't detect it. So if it is very accurate, why would we do subjective refraction? Subjective refraction is to verify and confirm the objective refraction. So you still need to do the Jacksonian cross cylinder in order to confirm that the patient doesn't have cylinder. And we already said that. If the vertical lines on the astigmatic fans appear more clear, then the horizontal meridian is more emmetropic than the vertical. Again, if the vertical lines are more clear, then the horizontal meridian is more emmetropic, or the vertical meridian is more ametropic. Is this correct? We said that also.
Yes.
Yes,
Yes,
exactly.
true.
The more blurred, the more ametropic. If the meridian appear more blurred, then it is more ametropic. If the meridian appear less blurred or more clear, then this meridian is the emmetropic. Here is the vertical lines are more clear, meaning that the vertical lines are more ametropic. They have astigmatism. That's why they appear clear. The horizontal meridian is more emmetropic because it doesn't appear clear with the astigmatic fan. So astigmatic fan is used to detect the eggs of astigmatism. So don't be confused that it is more clear, so it should be the emmetropic. No, it is more clear, meaning that the problem is in this meridian. This is the meridian of astigmatism. The best vision sphere should be assessed with the patient's second eye fogged rather than occluded. So which is better, the fogging or occlusion?
Occlusion.
Occlusion, why? No, fogging is always better.
Fogging. Okay, so it will relax accommodation both eyes. Yes.
The fogging avoid the accommodation. It will relax the patient's accommodation. So sometimes patients can accommodate over the cover that you are occluding over his other eye, so causing you more myopic shift. So the fogging will be better. The duochrome test should be used in all patients with compound myopic astigmatism.
No.
True.
True, yes, no problem at all.
Yeah.
Okay, so for the sphere refinement, how do we refine the sphere? If we are adding more plus, if the patient has better visual acuity or the same visual acuity, but if we are adding the more plus and the patients report worse visual acuity, then we shift to the minus. We add the minus 0.245 diopter, and then if the patients report better visual acuity, we leave it. So the only case we leave the more minus is if the patient has better visual acuity. But if the patient has the same visual acuity or the worse, then we don't leave the minus 0.25 diopters. Okay, this is the rules for spherical refinement. So and you can simply understand it by the rule, the famous rule of the highest plus and the least minus. You are just giving the patients the highest plus that give him the same or better visual acuity, and the least minus which give him the same or the highest visual acuity, or you give him the least minus that will give him the better visual acuity. We said that in the cross cylinder, after adjusting the spherical power, we adjusted the cylinder, and we have to detect if the cylinder is present. This can be done by the cross cylinder. So if the objective refraction didn't reveal the cylinder, it is your duty to discover if a cylinder is present or not. If there is no cylinder present from the objective refraction, please discover if there is cylinder. If there is present, then refine the axis and the refine power. So after discovering the cylinder, you just discover the axis, then discover the power. If there is no cylinder, then no problem. This patient has a sphere only. But as the question is asking, the Jeffersonian cross cylinder should only be used in patients with a spherocylindrical correction? No, it can still be used in a patient with a sphere. So how can we use a Jacksonian cross cylinder in a patient with a sphere? By detection of the cylinder. And how can we detect the cylinder? How can we discover the astigmatism? By placing the Jacksonian cross cylinder at 90 degrees and 180 degrees to check for astigmatism. Then if there is no preference of the patient or no preference reported by the patients, we place it at 45 degrees and 135 degrees to scan the oblique astigmatism. Again, if there is no preference, then there is no astigmatism. If there is a preference, we will start from there by checking for the axis and then checking for the power. In the astigmatic fan, as we mentioned also before, when we have more clear, if the patient say that the 80 and 90 and 100 are more clear, are more clear, then they are emmetropic. The more blurred, if they say that the 80 and the 90 and 100 are more blurred, then this means that they are more abetropic. Then this is the meridian of the astigmatism. Okay, this question regarding the binocular muscle balance. Regarding the binocular muscle balance, a cover test to detect any heterophoria. Heterophoria, is this correct or false?
False. Correct.
False, because heterophoria is detected by the uncover test. Sometimes the patient can have heterophoria and heterotropia, but actually the cover test will detect both of them. The heterophoria will be masked by the presence of heterotropia, because this is the actual purpose of the cover test, to detect the tropia, not the phoria. Maddox rod is a non-dissociative test for muscle balance.
Wrong.
Wrong. It is dissociative, meaning that the right eye see image different from the left eye. So it dissociates the image between both eyes. Image seen with the Maddox rod is vertical red line parallel to the line of the cylindrical lens.
Wrong.
Wrong.
It is perpendicular.
Perpendicular.
Vertical fusional range is typically 10 prism diopter. We said that last lecture. The vertical fusion, it is 10 diopter, 10 prism diopter.
Yes. 2
No.
No, it is only 2
No.
to 3.
2 to 3 prism diopter.
Yes, it is the same for the vertical and the fusion and the cyclotorsion. A decompensated phoria will result in uncrossed diplopia. Like if the patient has esophoria, and this is again a clinical question. If the patient has esophoria and it was not controlled by orthoptic exercises or by correction or by whatever maneuver, and it will now becoming constant. So it will result in diplopia. Is this diplopia crossed or uncrossed? It will be uncrossed. I will explain to you now. So the uncover test, what is the value of the uncover test? It is when you are covering one eye, the eye will turn inward under the cover. This is what's meant by esophoria. And when you are removing the cover, it will return back to its normal position. So the uncover test is used to detect the phoria, which is like hidden squint. The patient has normal ocular alignment in the primary position, and this esophoria is only detected under the cover. That's why it will be revealed by the uncover, not the cover. The Maddox rod is a series of powerful plus cylinders that will be placed in front of one eye, causing dissociation. What is meant by a dissociative test? Here, if this patient is looking to this white spot, the right eye will see a white spot, while the left eye will see a red line. This red line is vertical because the Maddox rod is placed horizontal. So the line is perpendicular to the direction of the cylinders in the Maddox rod. And if the patient is able to fuse both of these images together, then the patient doesn't have any heterophoria. If they are dissociated, the white spot is displaced from the red line, then this patient could have exophoria, esophoria, hyperphoria, depending on the direction of the cylinders of the Maddox rod. We spoke last time about the fusional vergence and the amplitude, and we said that the vertical fusional vergence is only 2 to 3 diopters, like the cyclodeviation, but the convergence is the most or the maximum is 15 for far and 25 for near. Divergence is a little less, just 6 diopter for far and 12 for near. And this higher amount of horizontal fusion will make you more comfortable when seeing this image than seeing this image, because you have a limited vertical fusion. So a vertical displacement of the images will be more annoying. Regarding the decompensated esophoria, so decompensated esophoria meaning that the eye is looked inward, or the both eyes displaced if the one eye has esophoria, and it is this esophoria is now decompensated, meaning that decompensation meaning that it becomes symptomatic, the patient has diplopia. So by meaning diplopia, you see two images. Uncrossed diplopia meaning that the right eye will see the right image and the left eye will see the left image, while crossed diplopia meaning that the right eye will see the left image while the left eye will see the right image. Uncrossed diplopia occurs with convergence or convergent squint, like esotropia, while crossed diplopia occurs with the divergent squint or the exotropia. It has also it has an explanation, but I already know that your brain is already overloaded with the information, so you don't need an explanation, and I will not go through this, but I will just please remember that for ESO, for convergence, it is uncrossed. The right eye sees the right image, the left eye sees the left image. For crossed diplopia, the right eye sees the left image, for the left eye sees the right image, and this is what happens in the divergent squint. I guess we have 2 or 3 questions left. Don't worry, we almost finished. Regarding the children, the visual acuity in children, a letter matching test is appropriate to measure acuity in 3-year-old child.
False.
So we cannot use a letter matching in a preschool child who is a 3-year-old.
Picture matching is best.
Yes, it is best, but it is yeah, but the letter matching is also appropriate. Like, I know that the picture will be good, but letter matching can also be done. Like, doesn't have any contraindication. Still, as this child is it is just a matching. The child is not asked to name the letter, or it is not asked to recognize the letter. It is just a matching. But instead of matching a picture, it is matching a letter. So it can be used for preschool children. With the rule astigmatism is present in the neonate. Well, I know that astigmatism is present in the neonate. I tried to search for that with the rule, but I actually didn't reach a conclusive. Some paper says yes, some paper says no. But what I'm deadly sure about that the astigmatism is becoming more against the rule as we get older. So this means that it could be with the rule astigmatism is present in the neonates. There is nothing against that. It could be with the rule astigmatism. It could be against the rule astigmatism. But the question, it didn't say that it is going to be the same.
So can we say like that hypermetropia is present in neonates and that's why it is wrong?
So what is the problem to have hypermetropia and to have also with the rule astigmatism? What is the contradiction?
Physiologically, neonates are more hypermetric. As they grow older, they tend to develop myopia. But regarding astigmatism, it is not related with the age, or it is neonate or infant or.
Well, no, actually, they are. I know that it is not related to the age, but it is the progression of the astigmatism is related to the age. This is what I'm stressing on. That it is the child can the unit can be born with the rule. That's why this sentence is wrong. This is why this sentence is right. Can also be born with against the rule. But as we get older, like in 40-year-old or 50-year-old, then if we have with the rule astigmatism, this with the rule astigmatism tend to change to against the rule astigmatism.
Yes.
Okay.
Yes.
An emmetropic child accommodating into orthoptist light at 2-3 meters will have neutralized reflex with no trial lenses. If he is emmetropia and he is accommodating at 66 centimeters, there will be neutralization of reflex.
Yes.
Yes, exactly. This is what I was just mentioning. Because by this accommodation, you are becoming more myope. You are becoming more myopia minus 1.5 diopter if you are accommodating at the light as 66 centimeters. So this myopia minus 1.5 diopters will be neutralized, then will neutralize the working distance. So even without a trial lens, it will be causing neutralization. Bifocal spectacles are useful in accommodative esotropia. We said that in the bifocal lecture, and yes, it's true. The full cycloplegic refraction should always be prescribed.
No.
False.
No.
No.
So this is what we were saying in the beginning of the lecture. So see what is the question is asking for. Is it asking about that the cycloplegic refraction should always be needed, or what is the method? It's asking about the purpose or the method. The method by atropine, correct. The purpose is always needed. No, it is not correct. So this is the Sheridan letter test, which is that the examiner is holding a letter, which is usually H or O or T or V or X. This is like simple letters for the child. And the child is just to have a set of letters, and then the child choose or pick the or match the letter with in his hand to the letter that the examiner is showing. If the patient is emmetrope and he is focusing on the light, which is around 66 centimeters, then he is just becoming more myopic of minus 1.5, which is meaning that this focusing or this accommodation on the light will make him a myopic of minus 1.5 at the point of neutralization. So the reflex will be neutralized even without use of any lenses. Like this. So he is now in the point of neutralization. This is for my clinical course. So again, this is for the non-refractive accommodative esotropia with high ACA ratio. Those patients who have non-refractive accommodative esotropia with high ACA ratio, they have orthophoria for far. When in the far, you can see that both eyes are aligned and the light reflex is central. But when they are looking to the near, when they are looking to a near target, then you see that the eye is looking inward, becoming more inward, like they have more esotropia. This is because of these children have abnormal accommodative convergence to accommodation ratio. In order to correct this, we need some glasses that will correct the near component without the far component. So we correct the far component with normal glasses, and in the near component, we add bifocal. You can see this. This is the bifocal. So when the child looks through the bifocal, this bifocal correct the accommodation that this child have. This child has abnormal accommodation. So when we are correcting the accommodation, the convergence will be corrected consequently. So they will not converge because they are not accommodating, meaning that the eye will be aligned. So this is the purpose of the bifocal lenses. That the bifocal lenses will correct the accommodation in near, so they will correct the convergence, so they will correct the isotropia. Okay, a question regarding the anisoconia and anisotropia. So we have this question and another question left. Only two questions. Anisoconia and anisometropia. Anisoconia can occur in the absence of anisometropia. We said that. Is it true or wrong?
Wrong.
So we hear about something like optical. Sorry. We hear something like optical anisoconia, in which there is anisometropia. But is there anatomical anisoconia?
Can be.
That can happen without
Yes.
anisometropia. Yes.
Yes,
So
yes.
anisoconia can occur.
Physiological anisoconia.
Yes. Anisoconia is present in 20 to 30% of spectacle wearers. I try to look for like any statistics about that, but I couldn't find it. But for me, it logically seems true. A lot of spectacle wearers have anisometropia, and it can happens between them. Binocular vision can be maintained up to the image size of 10%. We said that
Yes.
today. We said that today.
5%.
Is it 10%?
It was
5%. 5%.
5%.
5%.
Yes. Spherical anisoconia cause horopter to tilt vertically and horizontally. We will just postpone this question till the binocular vision lecture, where we will understand what is horopter, because it will take a lot of time to explanation. But simply, it is the horizon of vision in front of the patients, or so. I just can't help to explain. So this is what's called the horopter. It is the horizon of vision in front of the patient, and if there is spherical anisoconia, it will cause a symmetrical enlargement of this horopter, or it will cause a tilt vertically and horizontally. This is correct. A glass plate forms a simple isoconic lenses. So can be a plate of glass act as isoconic lenses. We said that also in the lectures. So a parallel plate of glass can cause angular magnification with no refractive power. It is isoconic. Yes, this is correct. So the anisoconia can be anatomical, can be optical. The anatomical can be due to difference in distributions of rods and cones, as a wider distribution as a disease called a CSR or central serous retinopathy can cause a smaller image than the other eye. While the optical can be due to anisometropy, as we mentioned, difference in the power and the position of the correcting lens, and the difference in the refractive condition of the eye, distance of the nodal point of the retina. They can be symmetrical or asymmetrical. So symmetrical meaning that there is distortion in all directions in one meridian, like this and this and this. And this is the asymmetrical. So it will be, the image is distorted differently in the different meridian. Like in the symmetrical displacement will occur in the case of horopter, which is the horizon of vision. The isoconic lenses mean that it doesn't change the magnification. These are the afocal lenses or parallel plate of glasses that will cause angular magnification with no refractive power. So as the question is asking, that if the glass plate can be a simple isoconic lens, yes, we can consider a glass plate is the simple form of isoconic lenses. Like if we place a plate of glass in front of the eye, it will cause magnification. Instead of that, there is no refractive power. This parallel plate of glass has no power, but just because it will cause angular displacement, it will cause that the image of the object appear more closer to the eye, so the angle subtended at the eye is larger, meaning that it will cause more magnification. So why we are not using these isoconic lenses to correct the anisometropy and the anisoconia, since they produce some magnification? Because the magnification is very limited, it's only 5%, and it's expensive and thick and heavy. Finally, as we mentioned, that the maximum tolerable level for anisoconia will be about 5%. Okay, let's come to the final question. So it is a question regarding the accommodation and convergence. A myope of -5 diopter with near point of 10 centimeters. So a -5 myopia, we expect that his near point will be at 20 centimeters. However, his near point is only at 10 centimeters. So why is this difference? This means that the difference is due to accommodation. So does this mean that the amount of accommodation is 5 diopters? Is this correct or wrong?
Wrong.
So what is the total power of this eye? The total power will be the amount of refraction that this patient has and the amount of accommodation. So the amount, the power, or he has already myopia of -5 diopters, and he has an amount of accommodation which is 5 diopters. The total power of this eye will be 10 diopters. And what is the near point of an eye with 10 diopters power? Can you tell me? Power equals 1 divided by F.
Yes, so this 10 diopter.
Is 10 centimeters.
10
or 1
centimeter.
meter. So this is correct. Okay, using the method of spheres, like if we are using -4 diopter sphere and the +2.5 diopter sphere, both result in visual blaring in a patient with amplitude of accommodation is +1.5 diopter. Meaning that if we are placing two lenses in front of his eyes, that one lens is -4 diopter sphere and the other lens is +2.5 diopter sphere, and the net result between them will be -1.5. -1.5. If this patient has an accommodation of already +1.5 diopter, the net result will result in visual blaring. No, he will not be blurred because he is, if he will be blurred if he doesn't have sufficient accommodation. Since that he has already accommodation, like the amount of accommodation that will overcome the degree of the myopia that is present in front of his eyes, he will be able to overcome this myopia. However, since even though that he will not be suffering from visual blaring, he will be suffering from athenopia or strain or headache from his eyes because of the constant strain. But he will not be blurred because he can see the image clearly, as he is still immetrope for this image. He has +1.5 diopters, and we are placing -1.5 diopters of accommodation of lens. Okay. The third will be a little bit difficult. Let me explain to you for the next slide. A patient with 8 diopter prism diopter of accommodative convergence has an amplitude of convergence of 3 meters angle, and his interpupillary distance is 60 millimeters. So is this correct? No, this is not correct. And I will tell you how can we calculate the amount of convergence in prism diopters. The normal ACA ratio is 6 diopters. So for each 1 diopter of accommodation, it is 1 to 3 to 1 to 5, meaning that for each 1 diopter of accommodation, there is around 3 to 5 diopters of prism diopters of convergence. So this is not true. Pilocarpine will reduce the accommodation convergence to accommodation ratio. So what is the pilocarpine? It is a myotic.
Yes.
This myotic will also cause spasm of ciliary muscle, So it will cause accommodation. One of the main side effects of pilocarpine, it will cause accommodative spasm. So when you are thinking about it, okay, but the pilocarpine will cause accommodation, and so it should increase the accommodative convergence to accommodation ratio. However, no, this is not true. Actually, it will reduce the accommodative convergence to accommodation ratio. So this is like a paradox. This is one of the well-known paradox regarding the pilocarpine. Do you know why? Because actually pilocarpine, the ACA ratio is or it is stimulated by the central near reflex mechanism. Like when you are looking to a near target, then the blurring of the image will stimulate the brain to do accommodation and convergence. This is a central mechanism. However, when you are putting a pilocarpine, you are inducing a peripheral accommodation, not a central accommodation. So this will result in that you are stimulating accommodation from a peripheral or from an outside trigger, which is the eye drops, the pilocarpine, not from the intrinsic mechanism of the central nervous system. So this will result in that the level of innervation required to activate the accommodation will be less. The brain will feel that there will be an accommodation caused by this eye drop, so it will not send the impulses to the ciliary muscle in order to accommodate or to contract. So this will result in that the accommodation and convergence divided by accommodation will decrease because of the decreasing the central reflex mechanism. Okay, so let's see some important notes about the amplitude of accommodation. So in this question, it is saying, or the first question, it is saying that a patient who had, it is not, just hold on. Like if the patient has myopia 5 diopter. So we have a patient who has myopia 5 diopters. So this means that his punctum remotum is at 20 centimeters. He can read at 20 centimeters because he has myopia of -5 diopters. Actually, but the question is saying that he can see, or his punctum proximum, well, while the accommodation is exerted, is 10 centimeters. So why is that? This is because of the accommodation. He can see with his myopia at 5 diopters of 20 centimeters, but this excess 10 centimeters because of his extra accommodation. So both myopia of 5 diopters and accommodation, both of them will equal 10 diopters, and the 10 diopters will make the patient read and his near point or punctum proximum at 10 centimeters. So the amplitude of accommodation is the difference in the diopteric power between the eye at the complete rest and at the maximum accommodation. And the range of accommodation is the distance between the punctum remotum and the punctum proximum. Regarding the how to calculate the convergence in prism diopters. So convergence in prism diopters, in order to calculate it, this can be calculated from this rule. This can be by the meter angle, or what's called the visual displacement in the meter angle. As in the question, it is saying that it is 3. So here, a patient with 18 prism diopter of accommodation convergence has an amplitude of convergence. The amplitude of convergence is measured in meter angle, which is the amount of displacement of visual angle. It is 3 prism diopter multiplied by the interpupillary distance in centimeters divided by 2. So the question is asking about the convergence in prism diopter, and we need just to substitute. So a displacement in the meter angle, it is 3 multiplied by the IPD. The question is saying that the IPD is 60 millimeter. So it will be 6 centimeters divided by 2. So 3 by 6. So it will be 18 divided by 2. So in this case, the convergence in prism diopter will be 9 prism diopter. So the question is saying that, no, it is not 9, it is 18. A patient with 18 prism diopter of accomplished convergence has amplitude of convergence of 3-meter angle and the IPD is 60 millimeter. This is not true. A patient with only 9 prism diopter will have an amplitude of convergence of 3-meter angle and the IPD of 60 millimeters. Is it clear? No answer?
Yes, it's clear.
Okay.
Yes, sir. Yes,
Yes,
sir.
yes.
Yes.
So this is the end of our lecture today. Thank you for surviving to the end.
Thank you, sir.
No, it is a tough lecture.
Good night.
Thanks a lot for your attendance, and I wish that most of these questions are more clear now, and you can study it with your mind enlightened as you read this question. So the next lecture will be the last lecture of the optics, and we will cover the instruments and some miscellaneous topics. I hope that you are coping well with your study. So the next time will be the end, and there will be optics exam, the same as anatomy exam. So best wishes for you.
I
Thank
have
you,
one
sir.
doubt.
Thank you.
Uh,
Do you have any question, any comment?
yeah, actually, I want to ask that for part one, is registration open on ICU website? Because I am able to log in, but the registration link is not there for part one.
Well, for registration, it will depend mainly on the country. Like some countries, yeah, it is very inconsistent. For some countries, they will say that it will open, and other countries say that it is not open. So I think that the best way is to just email the ICO yourself. As I told you, it is very inconsistent, and everyone say different price for the exam, different different conditions for either it is open for registration or not, and the ICO website itself doesn't show anything. So please, I hope that I can give you a clear answer for this question, but I am afraid that you need to ask the ICO yourself.
Okay, thank you.
Thank you. Okay, thank you, and we'll see you next lecture. Good night.
Thank you, sir. Good night.